Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Jon. How are you doing today?
I'm good. Thanks for having me on, Dennis.
Awesome. Since this is the first time on the podcast, would you mind doing just a quick introduction of yourself?
Sure. So I was a Special Forces medic, served with 5th Group, did a deployment with them to Iraq, and then moved over to 20th Group, did a deployment with them to Afghanistan. Then I went to med school at Duke. I did my anesthesia residency, and I did fellowships in pediatric anesthesia and cardiac anesthesia. And then I did congenital cardiac anesthesia as an attending at Duke and some adult cardiac anesthesia at Duke as well for a couple of years. And now I'm working as an anesthesiologist in Raleigh at Wake Med.
Hi, awesome. Well, you're definitely the dude to talk to because I want to talk about analgesia, multimodal analgesia, and how do I make these narcotics last? Because we don't get a hell of a lot of them. So just in my experience, medics, I'm guessing across the world, you have a favorite and you stick with your favorite, and that gets you through all your training lanes and everybody's happy. That's not necessarily a reality that you can just stick to and expect to go for forever with. I don't know. Was that your experience in 5th Group?
Yeah. I mean, both places you're kind of limited by what you have. So when I deployed, I think the first time to Iraq, I had, I think we had like Demerol. This was in 0506. So like the new combat guidelines were just starting to come out at that point. So we had Demerol, I think we had the transmucosal fentanyl then, and then morphine and Valium. And I think I had 1 or 2 vials of 100 milligrams of ketamine.
Yeah, that's almost, we didn't have Demerol or hydromorphone when I was in 7th Group, but yeah, that's pretty much the same loadout that we had. I guess one of the big problems I see is like, you're just kind of given, like, these are your narcotics. Like, go forth and do good things. I have a sneaking suspicion nobody did a lot of planning when they picked out how much narcotics you're actually going to get compared to the mission that you're going to be executing. So, just as an example, like, you're working in the OR, you do this on the daily. How do you plan for, like, this patient, I'm going to plan for this amount of narcotics and, so that you have enough and you're not running to someone else to get more?
Mm-hmm. So the patient considerations are important. So, you have patients that are opioid-naïve that have never taken an opioid in their life. And then you have patients that are on chronic opioid therapy and are going to require a good amount of opioids during a procedure, especially a painful one, to get them through the procedure and not in tremendous pain afterwards. So the opioid-naïve patients are typically pretty easy to take care of. We have sometimes we'll give 250 micrograms of fentanyl during a surgery, like I'm not talking like a super painful surgery, maybe a surgery that's a couple of hours. What you really want to focus on is taking care of the pain at that point in the surgery where the stimulus is the greatest. And so the patient tells us in their own way while they're asleep, if they're hurting. And so part of it is paying attention and watching what the surgeon is doing. And then the other part is sort of watching those responses from the patient. So patient gets, like I said, they will show you what they're feeling, even if they can't tell you. So when there's a surgical stimulus, they get tachycardic, their blood pressure goes up. And so those are the times you treat. And so you might give 25 micrograms and heart rate goes back to normal, blood pressure goes back to normal. And so when a patient is hypertensive in the operating room, the first thing we want to make sure we do is make sure the pain is treated, because you don't want to treat their hypertension if it's not, primary hypertension. If the problem is a pain problem, then you treat the pain, and the blood pressure, hypertension will then take care of itself. So you treat what you need to treat to keep the patient in this kind of homeostasis. And, when a surgery is very painful, like if we're talking like a bigger multi-hour abdominal surgery, you're probably going to end up giving more opioids. Now, the multimodal part of it is where we try to limit the amount of opioids, because when you're having a belly surgery, they are unique in that the bowels slow down. We don't want to further slow down the bowels with giving a ton of opioids. So the other things we do fascial plane blocks. We don't do a lot of epidurals. It's very unique cases where we'll do an epidural for a belly surgery now, at least where I work at currently. We try to do all these different things. So like fascial plane blocks, do ketamine, Tylenol, and certain NSAIDs if the patient's not bleeding or has kidney problems or ulcers or things like that. Dexmedetomidine works on pain receptors. It's an alpha-2 agonist. So like all these different pathways you try to hit so that, you get this synergy in treating their pain, because we know that acute pain leads to chronic pain that leads to, other things that we don't want: neuropathic pain, chronic opioid use, PTSD, and other pain disorders. Like if we can hit that pain where it's at its worst, the patient is going to do better in the long term. So it's just the more ways you can target pain in the OR, the less opioid you're probably going to have to use, the less opioid they're going to need as they recover, and hopefully the less opioid they'll need chronically.
I guess what I was thinking of, and yeah, absolutely, finding as many different ways to help treat the problem, you're going to ultimately be able to reduce the amount of narcotics of any kind that you're using. And that's just going to overall just be better for the patient. It's going to be better for you because you're not giving away your supply.
But the PFC setting, you're limited, right?
No, yeah.
It's a whole different situation. I can give all these things. I don't want to say an endless supply, but for a patient, or an individual patient, like it's not difficult to do these things. And I'm also comfortable using these medications because I use them frequently.
Yeah, you're doing this on the daily. So like on a given day, a given procedure, you're looking at the patient, you're looking at their patient history, and you're coming up with like at least a general plan. Obviously things change on the fly, and they can, but you have a general idea. What tells you like, hey, I'm going to bring, 2 or 3 vials of fentanyl and I don't know, propofol or Versed or, whatever is part of your plan. I guess what components go into that to make up that kind of decision?
So the patient's weight, like typically with military, you're dealing with
100 kilograms exactly.
Ish, 100 kilograms ish. For us, that can fluctuate a great deal, especially in my case, I take care of pediatric patients all the way up to your largest patient could be like a BMI of 80. So we take care of all shapes and sizes of patients. So that is something that probably makes it easier in the prolonged field care setting. But for us, that context matters. And then, like I said, do they use opioids? Are they on chronic opioids? Do they use other drugs? Do they drink alcohol? How much alcohol do they drink? Like, How many days a week do they drink? Are they on chronic benzodiazepines? All these things will shape your anesthetic plan. If you have an opioid-naïve patient, like I said, that makes it easier because, and somebody that is, doesn't have issues with substance abuse and things like that, because that a little bit can probably go a long way with them.
Also, guys, keep in mind, like, your patients don't always have it tattooed on their body, and sometimes they don't tell you the truth. So if they might say that they're naive to it, but they are really not. So also keep that in mind. You're going to have to adjust on the fly, and you're not going to know until you start pushing things.
Yeah, 100%. One
thing I think guys need to look at when you're coming up with whatever narcotics you're going to bring with you, not necessarily just patient weight, but think about like the mission, like how long is this mission? What is the likelihood somebody's going to go down for that? And a general idea of what procedures you might have to do, whether that be a chest tube or a crike. You're going to have to do a sedation dose with that, and you might have to maintain that, and you might have to maintain that for the duration of whatever that evacuation plan may be. And I would probably lean towards the side of worst case scenario evacuation plan, because it's so much better to have too much than way too little. But when it comes to just dosing, another side of things is just dosing effectively, and using your narcotics wisely, right? Not overdosing them, and just to make yourself comfortable, right? So, when you have that patient and, you're just starting to feel them out, how do you go about finding what is the right dose for this particular person at this particular time?
Right. So this is the best advice I can give to anybody is start low, see what your response is. Because like I said, not everybody's the same. You can give 12.5 micrograms of fentanyl, and a lot of people are going to say, well, that's too low. That's not going to do anything. It all depends on context. So if I have a patient that's very sick, 12.5 micrograms of fentanyl might be enough just to get them through. And if it does nothing, you can always give more. You can give 25 micrograms of fentanyl. You're probably going to have to wait a couple of minutes to really see if there's an effect. And so in the OR, we have the benefit the patient is completely anesthetized, like in most cases. And so general anesthesia, they're tachycardic. I gave 25 micrograms of fentanyl. They're not tachycardic anymore. So if you have, and I remember having the capacity to check heart rate. You can use your finger and a watch, worst case scenario. But I think we had pulse oxes that had the capability, and I'd be shocked if they didn't still at least have that. You want to monitor these patients when you're giving them these medications. You have to look at their heart rate, their respiratory rate, because, opioids, narcotics, they are going to decrease your respiratory drive. Benzos are going to decrease your respiratory drive. If you give enough ketamine in a short enough time, it will have effects on their respiratory drive, even though that's, not typically thought of as a side effect that we worry about. But when you give all these medications at once, they can, again, be synergistic. So I always say, give one thing, see what it does. And then if you don't get the response that you wanted, give more and keep doing that until you get the patient through what you need to get them through, or to the next, level of care. Because the worst, we don't want the patients to have pain. We don't want them to have these chronic pain conditions, but we also want to keep them alive. So, that's primum non nocere, right? Like first do no harm. That's what we're there to do. We're there to get the patient through. And if I can, get them as comfortable as possible and, try to avoid these pain pathways that happen later.
So one piece of advice, and I'm just more of a sanity check for myself, I tell the students, like, whatever number pops into your head for this drug, and I want to start at this dose. If you're dealing with a sick patient, just cut that number in half.
Yeah.
And start there.
Mm-hmm.
And then I ask, like, what's the worst thing that's going to happen? And they always say, like, nothing. I say, no, that's not true. Actually, the worst thing to happen is their respiratory rate does go down and their blood pressure does go down and all those bad things still happen, but it'll be roughly half as bad as if you had just sent the full dose. Mm-hmm. So, it always benefits you to start small.
Yeah.
You don't have to like hood slide and jump off the top rope to treat pain. We'll get there.
Especially if you're not experienced in doing it, you might just look at the book and say, okay, here's the dose, but like context matters. If the patient is unstable, like you said, at least cut it in half. Give the lowest dose possible that you can give, and then you can give more.
Yep. Too easy.
More.
Yeah. Another question I always get is about ketamine. And a lot of students will say ketamine is not an analgesic. It's a dissociative. Is there a difference? Is ketamine an analgesic?
So there's a lot of studies out there that show that giving ketamine as a multimodal decreases the amount of opioids that are that are used afterwards. So in my mind, that's analgesia in some form. And then the other thing about ketamine is that it's an NMDA antagonist, and a lot of these chronic pain pathways, they have this central sensitization. That's where all the chronic stuff comes from, right? It starts acute pain, like peripheral nociception, and that neurotransmitters get to, within weeks, start to work on central pathways, and a lot of that is NMDA related. So in my mind, ketamine makes a ton of sense to try and treat these pathways before they become chronic. And there's a lot of evidence for using ketamine in PTSD and things like that as well. So yes, I would argue that ketamine has a lot of benefit in analgesia.
And I know ketamine does hit those mu receptors just like the opioids do. It just hits like a bunch of other areas all over the brain and spinal column to get its full effect. But as far as pain control, would you be pretty confident using ketamine for just pain?
I probably wouldn't use it alone, but like the patient is going to tell you too, right? If they were in pain, and this is a patient that is walkie-talkie, and you gave ketamine, like you'd assess the response. Now, part of it might be dissociative. Yeah, that's true. I mean, ketamine is 100% a dissociative drug, but I would argue that a lot of those patients you're going to treat pain. That's why it's used in the emergency department a lot for, reducing shoulders and that kind of stuff, or reducing fractures and doing dislocations and things like that. So yeah, it's a little bit of both, which makes it probably a good drug to have in your toolbox.
Yeah, it definitely is. We mentioned earlier, like even a drug like ketamine, can have negative effects on a patient as far as hypotension. It's not necessarily the ketamine doing it to the patient. I think it's the patient's just, I don't hurt anymore. And so they start to relax. So you still have to be careful even with something really safe like that. But of the drugs to use on a sick person, I would definitely, I think that's a smart one to reach for. Now extending this out, that's the bad thing about ketamine and really fentanyl. It's really quick on. It does come off relatively quickly. So if this is what I have to play with, the temptation is just, we'll just keep doing that over and over and over and over again. Well, you're going to run out if you didn't plan really well, or you have more patients than what were expected. So now I need to start thinking about, how can I extend this out so I'm not using so much narcotics, just so I can make it last, for the duration. So, once you've come to this realization, how do I start incorporating? What do I start incorporating to help, move these things out?
Yeah. So, it's tough when you get a box, like a a 12-inch box with all your opioids and your narcotics, and ketamine. And so you got to make it last. And so it's like I said, start with the lowest dose possible. 10 to 20 milligrams of ketamine, and look for a response. I think doing an infusion is probably not the way to go in these cases, just because, one, I think there were some studies using ketamine in the intraoperative period that showed infusion versus bolus. There wasn't a whole lot of difference. Now, doing an infusion is more elegant. We love to do infusions in anesthesia, because typically your anesthetic record will be very stable. But if you don't have that luxury of an endless supply of ketamine, then you have to kind of wait and see what you get from the lowest dose possible that you can give. So 10 or 20 milligrams, let that last 20 or 30 minutes, and, then you're going to have to redose it. You're kind of limited in your options at that point, if you're in a situation where you're having to give ketamine.
Have you found a lot of variability in duration based on different patients or different patients' physiology?
So yeah, you can usually, if you're paying attention to the record, you can see when they need, it's like you give ketamine and then an hour later start to see, or, narcotic, fentanyl, hour later, you start to see the heart rate go up, the blood pressure go up. They will tell you I say this all the time, they will tell you in their own way when they need it. Now, if you have a patient that's chronic pain, that's on opioids, likely they're going to need more. And so whereas an opioid-naïve patient, maybe I can get them through that surgery with 250 micrograms of fentanyl. But that opioid-dependent patient, you're looking at giving hydromorphone, something that's a little bit longer acting, to try and get them through. Because like I said, it's that, there's been enough studies that show it's that inciting acute pain that happens. That's what we need to try and manage in the OR. And that's the patient isn't awake for that. They don't know that this is happening, but it has effects on their body in the long term. So if you can treat that point of incidence of where that pain is the worst, then that has profound impact down the road. We're finding that out, with studies that are being done now. So that's kind of my emphasis, is to try and treat this pain before it gets out of control. So try and keep it at this homeostasis if you can. But you really have to just pay attention to what the patient is, whether they're under general anesthesia or not. They're going to show you or tell you.
When it comes to just the multimodal aspect of things, what would be your first go-to? It's I'm going to try, is it Tylenol, a systemic type agent, or would you prefer to try and do regional blocks or local blocks or things like that?
So we try to do everything. We try to do everything that we can. So, for example, if we're doing an orthopedic surgery and it's amenable to a block and the surgeon is amenable to having a block, they don't always want a block, because sometimes they're going to do neurologic assessments after. And if we do a block, then we knock out their motor function, then they can't do what they need to do. So it has to be the right patient. But we'll do a nerve block typically before surgery, because like I said, if you can treat that acute pain before it becomes acute pain. So if you in theory, knock out the ability for those peripheral pain receptors to respond to the surgical stimulus, that's the most important thing. So we'll do a block before surgery, a nerve block before surgery. And then during surgery, we'll, use fentanyl, use Tylenol is usually my first option, because a lot of surgeons will be weary of NSAIDs, just for there is still a stigma that NSAIDs, and some of it is based on studies, but a lot of it is still stigma that NSAIDs impact the ability to heal, especially when it things to like certain orthopedic procedures. So typically Tylenol, ketamine, dexmedetomidine, which is an alpha-2 agonist, and then like occasional NSAIDs, Toradol. I don't really do a lot of ibuprofen. Typically, if we're doing NSAIDs in the perioperative period, it's ketorolac, Toradol, that will.
Any particular reason?
It's just kind of in our compendium. That's just kind of what we use. So we have the option to give ibuprofen in the recovery area. I just tend not to do it. There's not really any.
Okay. Now, how do you, so now you have multiple different drugs. You have blocks, you have, Tylenol, you have maybe, I don't know if you pick Tylenol versus Toradol. Do you combine the two? But you have multiple different drugs. They all have different peak times. They have all different onset times. They have all different durations. So how do you juggle all these different things to maintain the patient throughout?
So you just want to keep, if you're going to give these medications, you kind of have to keep doing it through that acute period. So Tylenol, for example, like it's typically in an adult, it's a gram IV or PO Q6 hours. So like my preference would be to keep giving that, over the couple of days.
So I guess differently than like your ketamine or your fentanyl, you're not waiting for like, oh, his heart rate came up. Like, well, it's Tylenol time now. Or
so those, like those drugs, the Toradol and the Tylenol, those are ones that I would be consistent about. Whereas the opioids, I would save those for the more like, okay, my pain is getting worse now. So if it's
so you
severe,
keep them on a schedule. Every 6, you're getting a gram of Tylenol, or hey, it's 2 hours or 3 hours. Say it's time for another lidocaine block or ropivacaine. I would imagine you want to use a longer acting one if you're doing that.
Yeah, usually we'll use most blocks that we do is ropivacaine. We don't. Sometimes we'll use liposomal bupivacaine, but that's beyond the, I think, scope here. So thinking of like what you would have if it's a surgical block. So for example, a supraclavicular block, if there's a, surgery on the forearm or the upper arm, you're using for like, if you're doing a surgical block, 0.5% ropivacaine, and, that's a surgical block. That patient technically could have the surgery done with just the block in a lot of cases. We'll do that on patients that are really sick. We'll tell them like, hey, you're going to be awake. Like this, we're talking patients with severe pulmonary hypertension, with pulmonary with pulmonary pressures that are super systemic. Like we're telling them You're not getting anything else. This is going to be your anesthetic, and get them through the surgery that they need to get.
Now, obviously, you're doing this before the surgery. Are those
Correct.
blocks as effective if this is after the fact?
So they'll last somewhere between 8 and 12 hours. So we typically do not redose them. Now, there's a lot of studies, and we don't do catheters at the place where I'm at now. It's a lot of maintenance and a lot of logistical support to like assess these catheters after the fact, and they come out, and then stuff like that happens. So we don't typically use them at the place I'm at now. I know that I think Chester Buckenmeyer, I don't know if you've ever had him on the podcast before, but he like the military regional anesthesia handbook. He was one of the authors of that. And so they did some studies that showed if some of these were continuous nerve blocks. So catheters showed that patients that got these nerve blocks and catheters for 24 months had improved pain. So like they didn't go down these chronic pain pathways that other patients did that did not get blocks. So we know that they work in the right patient. But yeah, before in my mind, it has to be done before the surgery.
Yeah. I mean, in your context, absolutely. In my context, I'm not going to numb the guy before he steps on the IED. I get the mess afterwards.
Yeah. And also you have to, like, if a patient's unstable, I think all of that data came from patients that were like tier 4 or something like that. Like that, these were not patients that were in like T-tri-C or even I don't think prolonged field care scenarios.
No, like most of these studies are going to be on relatively healthy, stable people with the bestest of care. Everybody else is stuck with us. So,
and then, well, the question then is too, like, I don't know. We were just starting to get ultrasounds in 2011, and
it's more common. It's definitely more common now. Usually they're not necessarily on individual teams yet, but they're getting more common, and guys are definitely getting more use out of them. They still have the STEMI-plex. We just haven't cracked the nut on getting those needles that connect to the STEMI-plex.
Oh yeah. Hard to use one without the other, and if you're not proficient in ultrasound either, then it's a problem. And it's something that you can't just break out once every 7 months, 8 months, a year and expect to be proficient at it. I'm to be honest, when I was in Delta, I don't think there's any way that I would have done a peripheral nerve block. I just wasn't comfortable.
Well, I mean, I have a book, so it's almost the same thing as like being good at it.
Well, that's the thing though, is like you have to know where to look, where to get your information. And some people are probably savvy enough to do it. I don't think I would have I don't think I would have been when I was in 18 Delta. I just didn't have enough hands-on experience with the ultrasound and a needle.
Now, I went through before there was ultrasound was common at all. Like we didn't even learn about ultrasound in the course. So we just did our little drawing the maps on the body and like stabbing a needle in and like fill her up, Mm-hmm. But yeah, as far as experience wise, we didn't really get that much experience. We did the blocks in the training. Maybe occasionally you do like some local blocks on your hospital rotation, and that was mostly it.
Yeah, I think I did digital blocks on a guy. Those are
super easy. Yeah. Now, when it comes to adding things like Mobic or Tylenol or anything else you want to add to this, like what other considerations are you thinking about before you do this?
So the big things are what, like individual patient considerations for those medications, right? So like with NSAIDs, bleeding has to be controlled. They can't have ulcers or gastric issues. Just because it's going to exacerbate that, you could end up with a bleeding ulcer. With Tylenol, do they drink? Are they a heavy drinker? Do they have liver disease, hepatitis, things like that? And then also with Toradol, like the NSAID, bleeding, and then kidney function is like they have to have kidneys that work. So usually not as much of an issue with healthy military age people, but it can be.
Like the Tylenol, heavy drinker, you could almost guarantee it's yes. Liver cirrhosis, hepatitis
thing. A whole lot since I was on teams.
Yeah, no, just the flavor. That's all. But we have a community of alcohol, but things like cirrhosis, hepatitis, jaundice, anything like that. No. Would you still use it?
So if I had a guy that drank, I'd probably still use it. If I had a guy with known hepatitis, I'd probably be a little bit more cautious about it.
How much bang for your buck can you get out of using these kind of adjuncts to extend things out?
So I remember looking at a study that showed if a patient in the emergency department didn't know what they were getting and they got IV Tylenol versus morphine, there was no difference in pain scores. So now that may be placebo part of it.
Sure.
But
does it matter?
A lot of patients that will say like Tylenol doesn't work. It's just because you can get it over the counter, but it's an effective medication. Data backs it up that it works. It will, if you use these medications together, it has an effect. If you use Tylenol on its own, it has an effect. It's just a lot of patients feel like it, if it's a medication that they can buy over the counter, that it can't possibly help, but it does.
So just walking through how this would look. Okay, so I've been doing fentanyl up until this point, 25, 50 micrograms, maybe somewhere up to 100, somewhere in there, of fentanyl bumps to get this guy through. Now I want to start incorporating, Tylenol. Okay. Do I change my pain scores? Like, I don't expect Tylenol to really affect my blood pressures or things like that. So you just add it in and then just kind of continue as far as like when they start coming off your goal or their pain scores start coming up or you start seeing, their respiratory rate, etc., start being affected, and then you redose with your fentanyl, or like how do you incorporate this?
If I know that somebody's going to have pain, I'm not worried about the Tylenol. The Tylenol I'm just going to start giving and give it consistently.
Okay, and you just do that every 6 hours?
The thing about Tylenol, there's multiple ways you can give it. Even if you had to give a rectal dose, you could give a rectal dose, although I'm sure most guys on teams aren't going to care for that. But maybe they can't take oral. Maybe you don't have the IV version. And so you have a lot of ways that you can give Tylenol. So yeah, I give that, like I said, consistently. As soon as I know that somebody's having pain, like a lot of times we'll give Tylenol in pre-op. So, and then, like I said, just give it consistently after that, as long as they're still having pain and in that acute period. And then the narcotics like fentanyl, stuff like that I titrate, because that is only, I'm trying to give that especially outside of the surgical period.
Yeah. You're just doing that for your breakthrough type situations, and then your Tylenol or whatever adjunct becomes kind of your base of your analgesic plan there.
Yeah. And then once they're taking orals, also stuff like oxycodone, we're talking about opioid-sparing, but if the pain is not being touched with whatever they're getting, then, you have to do what you have to do. If the patient is in severe pain, then you treat the pain. Our goal is to try and, as soon as they don't need these medications, to start taking them off.
Yeah. That's another thing is, guys, you have to get used to, we're comfortable adding more. We're relatively comfortable adding more. Like if you see somebody running a drip, generally it's just going up, 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 up as far as the rate. Rarely, at least in my experience, am I watching it also go down, based on what the patient's physiology, what the patient is telling you. Because we really, really, really hate watching our friends be uncomfortable. So, he twitches wrong, like, oh, he's getting a bump of whatever. But guys, you have to be comfortable not only going up, but you also have to be comfortable going down on your doses, withholding doses for longer periods of time. Like, let them start showing you, like, I'm actually in pain, and then treat the pain.
Right. And this is like a common thing with anesthesias, where you'll go out and see the patient, and you'll get a call that the patient is in 10 out of 10 pain, but then you get out there and they're sleeping. So when in doubt, go check the patient. You have to use your common sense also. Like, the pain scores, it's part of the problem while we're in this opioid epidemic as it stands, is that we became so reliant on these pain scores, and that we always have to treat, that number. And that's why we have however many million people in the United States that are on chronic opioid medications.
Yep, absolutely. So Jon, do you have anything else we need to chat about when it comes to multimodal?
I would just say use everything at your disposal that you feel comfortable using. And if you don't feel comfortable using it, you need to try and learn, because the medications that we get primarily, and we talked about it earlier, the benzodiazepines, the opioids, those are all respiratory depressants, and they all, they have that synergistic effect on the respiratory center. So if you can use other things that don't hit that as much, it's going to benefit your patient, especially when it's difficult to place all your resources on one person and observing them and assessing them. And so once you give these medications, you're kind of bound to do that. So the more you can avoid giving these medications, it allows you to do other things, to work on other things. So work on other patients potentially. So, I know it's going to be a lot of folks' first thing that they pull out is to give, fentanyl or benzos or whatever they have, but just think, what are the implications of this? What does it do to the situation? Because now I got to watch this person. Right.
Absolutely. Well, thank you, Jon. I really appreciate you jumping on.
Yeah, of course. Thanks for having me on, Dennis. Good to see you, man.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.